All right. So, uh, hello there, everybody. This is Jose Maimani. I'm one of the medical oncologists in Longmont with RMCC. And today I have with us Dr. Patrick Richard, who's a radiation oncology specialist who practices in Boulder with us at RMCC. Patrick is going to round out our discussions on prostate cancer for the end of Prostate Cancer Awareness Month. We've had talks from Dr. Barnett on the medical oncology side. Josh is one of our genetic counselors, and now Dr. Richard discussing the role of radiation in prostate cancer. This is a topic that's always discussed as far as surgery and radiation. So I'm personally very excited to tune in and watch this. Dr. Richard grew up in New Orleans, did his medical training at Tulane, and did his residency training in radiation oncology at the University of Washington. He's been with us at RMCC for multiple years now, and he will go ahead and take it away. So thanks, Patrick, for doing this.
Absolutely. Thanks for that introduction, Dr. Maimani. I'm also very excited to be presenting on prostate cancer radiation. And I've titled this accordingly, explanations to support informed decisions. My personal approach with my prostate cancer patients is to really give them as much information as they want regarding the treatment options. And we see that there are quite a few options for prostate cancer radiation. So I'd like to kind of dive into those ideas today. And certainly we have time at the end for directed questions that I'm happy to answer. As Dr. Maimani said, I practice in the Boulder location. These are just some screenshots down here at the bottom. Let me share my screen first. And here's some screenshots down here at the bottom of our beautiful clinic up here on the grounds of Boulder Community Hospital. So what I'd like to just provide a brief outline of what I'd like to be discussing today regarding prostate cancer. I really want to focus more on the treatment decisions and options that we have available, but really to set the stage, talk about some of the details that I go over at length with my patients, because there's just multiple different options for the different stages and risk groups for prostate cancer. So I want to briefly go over that, but then, like I said, focus most of our time on the different options and techniques. I will be focusing a little bit more heavily on our external beam approaches. That's kind of the more commonly utilized radiation option for prostate cancer, and one that I particularly specialize in. But then want to close it out with some of our newer ideas and what I call add-ons for prostate cancer radiation. So these are those details that I look at. I start out all of my prostate cancer consults by going over these very important concepts. One is the initial PSA. PSA is a fairly specific marker for prostate cancer, and we see varying presentation values that can suggest how aggressive the cancer is and the extent of the cancer. So that's an important value that we talk about. The next is the results of the DRE or prostate exam. A lot of cases we don't feel a lot of abnormalities on the prostate itself, but certainly when we do, raises our suspicion a bit for more extensive disease. I spent a lot of time going over biopsy results because there's a lot of information that we gain from those biopsy results that help determine the best option for our patients. And one thing we often discuss is the Gleason score, which is really a measure of how aggressive or abnormal the prostate cancer cells look under the microscope to our pathologist. We grade these from 3 to 5, 3 being not as aggressive and 5 being on the more aggressive end of the spectrum. And we report those as one number plus a second number, which I have an example of here for a total Gleason grade. Once again, we bring it up because different Gleason scores can really mean more or less advanced disease and impact treatment options. I also look at how many specimens are positive in that biopsy result, and whether we're able to ascertain if the cancer has extended past the capsule of the gland, which we call extraprostatic extension. So the biopsy results are very key, and I think spending adequate time going over those with your radiation oncologist is very important. Lastly, there are some cases where we would recommend additional imaging to help us understand prostate cancer. In certain situations, we are more or less suspicious that there could be cells extending outside of the gland, either in the regional lymph nodes that we'll talk about later or elsewhere in the body. And that's the role of imaging, is to determine whether that's been the case. Briefly touching on the risk group, this is something that as you see providers for prostate cancer, something that you should definitely understand, which is where on the risk spectrum you are with your prostate cancer. This is an NCCN risk grouping of basically spanning from a very low risk category to a very high risk category, and then there's some categories in between. So it's important to understand, once again, where you are in that spectrum, because there are certainly different treatment approaches depending on whether you're very low risk. For example, some of those cases we watch for a while. We call that active surveillance, versus very high risk, where you may not only need surgery or radiation, but also the addition of hormone treatments and things of that nature. So with that basis, I'd like to switch gears into going into the details of radiation treatment options for prostate cancer. The two broad categories that I discuss with patients are internal radiation, which we call brachytherapy, or external beam radiation. I'd like to start off first by discussing these internal radiation treatments, which we call prostate seed implantation. A lot of people commonly refer to them as seed implants. This is a permanent type of implant that's actually a combination of radiation and surgery, because it requires a minimally invasive procedure to actually get those radioactive seeds into the gland itself. They're very small, almost the size of a grain of rice, and they're strategically mapped out and placed in and around the prostate gland to deliver the dose from the inside of the gland, and there's some dose that extends outside of the gland. One of the benefits of this approach is, one, it really it takes a short operation, short length of stay in the hospital, and really, as you get further and further outside of the prostate gland, the dose of radiation rapidly falls off to where, several centimeters away, you wouldn't expect very high potent doses of radiation. So essentially, it's putting that source of radiation right where it needs to be in the prostate gland. The cons of that approach are, it requires an operation to undergo, and some patients either are leaning more toward an operation or not. And as you put these needles with the seeds into the gland, you can get some swelling of the gland, some irritation. So really, it relates to the baseline urination function of the patient. And I see guys all the time that are reporting obstructive symptoms. They can't quite empty their bladder, can't produce good urine flow. And I'm a little bit more cautious with recommending prostate seed implantation in those patients, because that gland can really swell up and really make those symptoms a lot worse. Because we are actually using live sources of radiation in the gland, patients are radioactive. And we commonly get this question as radiation oncologists. People ask us whether they're doing internal or external. Am I radioactive after this treatment? And for this, there is a degree of radiation being emitted from the pelvis. And so there is caution. A lot of older guys getting treated for prostate cancer have young grandchildren, and so it is a potential that you are exposing them. There's different ways around it, but you are considered radioactive to some extent in the months after this implant. Wanted to just show you an example of how this looks. So the image on the left here is a basic X-ray of the pelvis, where you see these high density seeds scattered in the location of the prostate gland. I would say that looking at how many seeds are used here, this would be a very large prostate gland that they've put seeds in. And on the right here, this is a CAT scan image of the seeds. They stay in permanently, but eventually they will become inert. They won't be emitting radiation, and the treatment essentially at that point is done. There is another form of prostate brachytherapy called high dose rate. What I just talked about, the seeds, is considered low dose rate, because each one of those seeds emits a low dose of radiation. They all add up together, but it's considered low dose rate radiation. A newer approach is to consider high dose rate prostate brachytherapy. This is a temporary form of internal radiation. This is a situation where it does require catheters into the prostate gland like you would put the seeds, but you're putting these tubes or catheters strategically in the prostate gland. And then what we do after is we place these radioactive wires into each one of those catheters, and they sit there for a certain period of time to deliver the dose of radiation. It's temporary because after that one treatment is done on that given day, the catheters come out, the tubes come out, but it does require on another day of treatment to replace those tubes. So this is delivered in a couple different treatments, so not one procedure like the seed implant. There's a few different procedures that need to be done, and it is minimally invasive. Overall, it's very well tolerated. It's an effective form of treatment for prostate cancer, and it's convenient that you only need a few treatments of it. The cons are much of the same considerations that I mentioned for the prostate seed implant, is that guys with a lot of baseline obstructive symptoms, difficulty passing urine, could have some irritation, inflammation that makes that worse. And this is kind of a specialized form, so it may not be available at every cancer center that you may see your physicians at. This is how it looks. This is a schematic of the procedure itself. This is kind of a sideways view through the pelvic area. You have, if you can see my cursor, you have the prostate gland here. They've kind of zoomed in on it. But what you see is these what they're calling thin hollow rods on this diagram, is those catheters that I talked about. You place them around the prostate gland, and then we strategically place these radioactive wires that will go through that catheter into the gland, and it sits there for a while, delivering the dose of radiation. You pull it out and then move into the next catheter and so forth. It's minimally invasive with those catheters, and it does require a probe per rectum to be able to visualize that gland under ultrasound. So those are the two basic forms of prostate brachytherapy or implants for prostate cancer. Switching gears a bit to the next broad category of radiation would be what we call external beam approaches. So this is delivered very differently. This is all non-invasive. So there's really no procedures that need to be done. There's no anesthesia. There's no needles or seeds or anything that we place in the gland. It's all delivered externally. And by that, I mean our patients lie on our treatment table and they're positioned underneath our radiation machines that we call linear accelerators. The machine rotates around them from different angles and delivers the radiation from the head of that machine down through the patient. So it's similar to what people undergo when they get an X-ray or a CAT scan or something of that nature. There's different energies that we use that I'll go into in a bit. But within the broad category of external beam radiation, we have two different types that you'll see here, photons and proton beam. The first one I'd like to discuss is proton beam radiation. Many of my patients that visit with me in consult are aware of this technology, and a lot of them ask really good questions about it. So I'd like to kind of compare protons and photons. It's a useful comparison. I'm going to take us back to our high school physics lesson where we learned about the nucleus of an atom, and that there's a positively charged and negatively charged particle. The positively charged particle, as we know, are the protons. And there's very sophisticated high-tech machines that are able to extract protons and accelerate them for therapeutic use. And that's how we are able to generate beams of protons. It requires very specialized centers to deliver this type of technology. And unfortunately, they're not available in every state. And Colorado is a state where we don't currently have proton beam treatment availability. Certainly, I have patients that have been interested in it, and we've kind of the closest to Colorado would be in Arizona or down in Texas, certain parts of California. And I've had people go out there to get treatment because they feel it's most appropriate for them. But that's one of the cons of it, is that it's not widely available. If you don't have the means to travel out of the state, it may not be the best treatment for you. The benefits of this and how it really compares to our photon treatments is the way the particle behaves. We are able to calculate essentially a stopping point of a proton beam that really is impossible to do with an X-ray or a photon beam. We're able to calculate that so that when it reaches its target, goes a little bit beyond, you can actually stop the beam of radiation. So what it does is it reduces the low and moderate doses of radiation past where you're targeting. In this case, it'd be the prostate gland. And so that's that's really how all this got started, is that we were looking for ways to potentially improve the side effects, the toxicity of our radiation. And this has been one of the most recent advancements in our ability to do that. I'll explain that it really hasn't, for certain types of cancer, hasn't taken off as quickly as many had hoped for. Prostate cancer is one of them. We still are really waiting on some really high quality clinical trials to really show us whether this is a better approach than some of our more standard treatments, and we don't have that data, so that's one of the cons of this approach. It's also very costly because the development of these centers, the big machines, the high-tech nature of it really leads to a very costly treatment. In some cases, 75% greater cost than we see with other types of treatment. As you can imagine, insurance companies are not too thrilled with that. And so it can be a very effective form of treatment for prostate cancer. I'd like to see a little bit more data to support it in terms of how much beneficial it is. And that could really make us want to use it a little bit more. I wanted to show you a couple examples here. The image on the left is obviously not a prostate treatment, but it's actually a pediatric treatment. And I think any discussion of protons needs to at least discuss one reason that we can really all agree on that is the best situation to use proton beam treatment in, which is for pediatric cancers. Because you're able to stop that beam for certain types of pediatric treatments, and I'll explain what this example represents, you can really avoid a lot of low and medium doses of radiation to any of the growing, developing organs in a kid's body. The type of treatment that I've depicted here is called craniospinal radiation, where we radiate the brain and the entire spinal area of a child for a certain type of CNS malignancy. The image on the left is a proton treatment. And just to give you a brief overview of what we're looking at here, the red is kind of the higher doses of radiation, orange is a little bit less, and the blue that you see here is the low and medium doses. The way we design these craniospinal treatments is we come in with beams from the side and beams from the back. And really with the proton treatment, as you can see, there's none of that low and intermediate dose going through any of the front part of that child's body. Compared to some of the photon treatments with those same beam arrangements, you see quite a bit of that low and medium doses. Low and medium doses in and of itself is not particularly damaging, except for when you're dealing with a kid who has growing organs and tissues, etc. The example for prostates are on the right here. The proton treatment is on the left, and the IMRT treatment, which I'll explain a little bit, is on the right. And they use different beam arrangements, but as the beams enter, you see some of that low dose, they get to the prostate, and then there's not as much of the low and intermediate doses going elsewhere in the body. You see a little bit more of that with the IMRT treatment. So that's one of the pros of the protons, but some of the preliminary studies coming out investigating that technology hasn't quite panned out in terms of less side effects for our patients. So it's still an active area of investigation. Every case is a little bit different. So I encourage you to talk to your radiation oncologist about whether they feel protons is best for your particular situation. Moving right into photons, which is the X-ray type of treatment. Like I said, this is what many people consider the standard approach that treats the majority of our prostate cancer patients that choose radiation. The majority of them are going to get a photon-based external beam treatment. So many consider that the standard. We have decades of good quality phase 3 trials, not only demonstrating the efficacy of it, the toxicity profile of it, but also how it compares to some of our other treatment options. It consists of different energies of X-rays. And like I was mentioning before and showed you on those images, photons, X-rays, behave quite differently than particle treatments. We cannot stop those exiting beams. Now, they're not exiting with large dose, it's small to moderate doses, but still, based on the physics of that beam, we cannot stop it. And so it does theoretically put more dose into other parts of the body. As it compares to the seed implants or some of those implant-based approaches, external radiation is delivered over weeks of treatment. And that's one of the cons that our patients see sometimes, is that maybe they don't have that length of time to spend getting their treatments. They want something a little bit more efficient. And so they kind of lean more towards some of those surgical approaches. But a typical external beam course, and I'll get into this in a little bit, is anywhere from 4 to 9 weeks of treatment. And that's daily, typically Monday through Friday. The pros of this approach, once again, is that there's good quality data. We know quite well what the safety and effectiveness profile is. Doesn't require you to travel out of state, so it's a very convenient approach that should be available in your community. And in general, it's an easier positioning and setup process. The cons of it is that, once again, it does require some weeks of treatment, and we have that exit dose issue that I've described before. To go in a little bit more into the planning of external beam radiation, once you've made a decision to go forward with this approach, the next step is to go forward with what we call a CT simulation scan. What we're simulating there is the setup position. It's a relatively comfortable position. You're on your back, as you can see in this photo here, with your hands resting on your chest. We do place a device around your pelvis and your legs. You can kind of see it in this photo as this blue structure that really is almost like a bean bag that we suck the air out of, and kind of really allows us to mold it to your pelvis and your legs to verify that that's going to be in the same position. And then we do a basic CAT scan with that setup. One thing I've written here is that we do have a little bit of prep work for our patients undergoing external radiation, and that's by drinking a certain amount of water and trying to empty the rectum or reduce the gas in the rectum. The reason we do that is for anatomical reasons. The organ that sits right on top of your bladder is the small intestine. When the bladder is empty, all that small intestine dips down into the pelvis, where we're delivering some of these high doses of radiation. So by keeping your bladder relatively full, it moves that small intestine up and out of the way, and it can effectively reduce the severity of side effects. Same thing with the rectum. We like to have as minimal gas or distension or enlargement of the rectum as we can. And so having a bowel movement or reducing the gas there can help us localize the treatment. Planning takes about a week for these external beam approaches. And there's a few techniques that I wanted to mention. And these have become the standard approach for radiation. So it's very likely you would be treated with either what we call an IMRT or VMAT approach, but it's always nice to check in with your radiologist to make sure that they're using some of these more sophisticated approaches. IMRT, which is also referred to as intensity modulated radiation therapy, is something that was developed in the late 80s, early 90s, and actually prostate cancer was one of the first situations where we employed that technique. Before that technique, we were actually treating a lot of prostate cancer with 4 fields of radiation that wouldn't allow us to really tightly wrap the high dose of radiation around the prostate gland. We were delivering more high dose to the bladder, more high dose to the rectum and other organs. And so this has really been a game changer in prostate cancer treatment. And like I said, we've been doing it since the early 90s, has an excellent track record. But what it does is it uses more beams of radiation. So instead of those 4 beams that would essentially create a box around the prostate, we use anywhere from 7 to 9 fields of radiation that put a little dose in wherever they enter, but where they all converge is the high dose, and that's right at the prostate gland. The analogy I like to use for my patients is an asterisk. You know, if you can imagine those lines all coming in, right in the center of that is our target, and that allows us to have a lot more conformity in our dose so that it's wrapping very nicely around the prostate gland and not putting a lot of high dose out. Taking it a step further has been some of our newer technology called volumetric arc therapy. We term that VMAT for short. Instead of having 7 to 9 individual fields, What this is it's an arc, a continuous arc of radiation around the prostate gland. So essentially several fields that are just continually rotating around. It lends itself to a more efficient delivery because of the beam not having to stop at each angle. We can continuously rotate the beam, and it leads to shorter shorter durations of each treatment, which makes it a little bit more efficient for our patients. But once again, whether you're getting an IMRT or a VMAT approach, the goal is the same, which is to tightly wrap our dose around the prostate gland to be as precise as possible. And it's, a better tolerated treatment than some of our older techniques. Logistically, with external beam radiation, the irradiation appointments are anywhere from 15 to 20 minutes each day. Most of that time is spent with our radiation therapists properly positioning and setting up our patients. And the beams, every case is a little bit different, but the beams may only be on for about 5 to 7 minutes, depending on the extent of the plan and where we're treating, et cetera. So it's a relatively short process. So whereas you do have to come in Monday through Friday for your treatments, we tend to make it as efficient as possible so that you can get on with your day. Treat a lot of working patients with this that can just take a quick lunch break and get their radiation, or just do it at the end of the day. So we make it as convenient as possible. This is an example of a photon external beam treatment. This is a treatment that I delivered at our Thornton clinic for one of our patients there. A few things to describe here. You see different colors of lines here with some numbers. These represent the kind of the prescribed dose of radiation, with 100 being the full prescription dose and 50% being the half prescription dose. So we really look, when we evaluate these plans, and sometimes it can take quite some time to evaluate the radiation plan. What I'm looking for is that these higher doses are tightly wrapped around the target, which in this case it is. We have the bladder that's right in front of the prostate, and we have the rectum, and you can see some black stuff there, which is gas. So we try to reduce that as much as we can, because as you can see, some of these doses are getting very close to the rectum, and our job is to make sure that we're not overdosing certain parts of the rectum. This is actually an arc-based treatment, and this, you can see kind of this almost like, looks like, oops, let's go back, a railroad track going around the pelvis. And if you can imagine, our machine is going to rotate around the pelvis very slowly to deliver the radiation. What's happening in that process is we're modulating the intensity at each point in that arc. And the way we do that is what's depicted here on the right side of the screen. These are what's called multi-leaf collimators, MLCs for short. And this is a nice depiction using a light, but basically these are leaves that come in at different angles and slide in and out of our treatment fields, depending on what's in the beam's path at that given moment. So for example, if you turn your attention back to the left image, as we're making that arc around, we'll get to a position where that arc is right in front of you, right in front of our patient, and what's right in the path there is the bladder. And so in that particular instance, it may want to block out a certain period of time around the bladder. And so these leaves will customize the field of radiations to that particular part in treatment and that particular patient's anatomy. So this is a highly customizable treatment. That's why it takes us the better part of a week to come up with these plans, is that we're looking at all the organs, looking at all of our fields and arcs to make sure we're properly and accurately delivering that treatment. So switching gears, as I mentioned on a previous slide, our external radiation approaches are typically, delivered over a period of about 4 to 9 weeks. And we call those different regimens. And, before we get into that, it's really important to understand that prostate cancer responds to high doses of radiation. We use radiation for many different cancers and situations. Some cancer cells are very susceptible to even low doses of radiation, and some are not. Prostate cancer tends to be on the higher end of the resistance spectrum to radiation. And so there's been some really nice studies done decades ago demonstrating that we need higher doses, and we have an idea of what that dose is. When those were first researched, we did not have really good, accurate ways of delivering the radiation like we do now. This is decades ago. And so the idea was, well, we know the radiation, we know that we need to get good dose, high dose of radiation to the gland, but that the organs around there, the bladder, the rectum, the small intestines, are actually quite sensitive to that. So the way around it was to do what's called standard fractionation. I've just realized I've mislabeled this. There should not be hypo in this word here. It should be standard fractionation. So I apologize for that. But standard fractionation is a slow delivery of radiation. As you can see here, I've the standard dose of radiation per day at that time was 1.8 or 2 units of radiation per treatment. So the idea was just go slow with your delivery, give a small amount of radiation to the patient each day, and over time that builds up, and you're going to finally get to that ultimate high dose of radiation that's the most successful to prostate cancer. The downside, obviously, is that that takes a long period of time to get to that high dose. And usually these courses of standard fractionation, and I'll correct this word here, but is usually about 9 weeks. That's kind of what we had done for a very long period of time, delivering nine weeks or 45 treatments of radiation. It's very effective. Patients tolerate it very well. But recently there's been a push to shorten these regimens because a lot of patients were not happy with coming to see us for 9 weeks. We think of ourselves as very pleasant people, but yeah, asking somebody to come in for 45 treatments is a lot. And so there's been some recent efforts over the past decade. Now that our machines are able to deliver more precise treatments and avoid high doses elsewhere, let's take a step back and shorten up some of these regimens. See if we can give our patients a slightly higher dose of radiation each day to see whether we can quickly give the treatment and still have that effectiveness and side effect profile of the longer regimen. And that's what we call moderate hypofractionation. Hypofractionation refers to fewer treatments. So we're treating over fewer treatments, but every treatment you get is a little bit higher potency. An example of that would be using 2.5 or 3 units of radiation per day as opposed to the lower dose I just discussed. And these treatments are significantly shorter. The duration is going from 9 weeks down to about 4 to 5.5 weeks of radiation. There's a little bit of a range there depending on where we're treating, but it shaves off the better part of 4 or 5 weeks of radiation, which is very impactful for our patients to get done a bit sooner and to move on with things. As I mentioned, there's been many different trials, good quality phase 3 trials that have looked at these approaches compared to what our standard course had been. And for the most part, the consensus is that most patients are equally served with these shorter regimens. Even at the higher dose per day, we don't see a consistent theme of increased toxicity in those studies. And we still see about the same effectiveness. And so for a lot of our patients, we have really shifted towards recommending more of these shorter regimens than the longer course. I treat both, and obviously with the convenience of the shorter regimen, most of our patients are electing for the shorter course, but occasionally we have some that want the longer course. The newest thing that has changed up our regimens a bit is what's called ultra hypofractionation. So not moderate high dose a day, but really high potent doses of radiation that are delivered each day. So this is a way to really rapidly accelerate the delivery of radiation. And instead of using some of those other doses, this is about 7 units of radiation per day. So it's more than double than some of these other approaches. The benefits, obviously, is that you can really rapidly deliver this dose, usually given every other day for about 2 weeks. So it shaves off even more treatment time. But we're limited a bit in our understanding of this type of treatment. We call it SBRT. CyberKnife is a platform that's also can deliver these treatments. And we still don't have a clear sense of really the safety of this type of regimen. Really, a lot of guidelines say that if you want to consider it, it should be as a part of a clinical trial because we're just trying to gain more information about it. It is tempting because it's very convenient. A lot of patients are very well served by this technology, but I would really encourage you to discuss it with your radiation oncologist to see how comfortable they are with it, because it is a little bit newer, and we're still lacking some of the comparative data that can give us a better sense of it. But personally, I'm excited by the way that treatment is becoming a lot more effective and efficient for prostate cancer, because once again, 9 weeks of treatment was very long. A lot of patients it was a big turnoff to a lot of people, and now there's some more convenient regimens that we can explore. Another important thing to understand is, what are we targeting? This is something that a lot of patients don't think to bring up, because they just assume, well, we're targeting the prostate gland, right? And there's nothing else that we could consider. And that's not the case. I always bring up targeting with my patients because it's helpful to understand what we're treating, what the course is designed to do, and where the risk is with their cancer. So obviously the prostate's always included. That's where biopsies show that there's active cancer. We always need to include the prostate gland in and of its entirety. And I made a little note here that we also put margins. That's a key concept in radiation oncology, and one that I often get from patients, which is, well, where's your dose going? How are you sure you're not missing? How are you sure things are accurately being delivered? And that's with our margin expansion. So we know where the prostate is. We put small margin expansions just in case it moved a little bit or the setup wasn't as accurate as anticipated. There's always a little room for margin there, and that's what we do. So it's the prostate gland. It's a little bit of tissue around it as our prime target. But really what I wanted to bring up is the pelvic lymph nodes. I had mentioned this before. It's a little bit of a controversial topic, whether we need to include the pelvic lymph nodes, in what situation should we include the pelvic lymph nodes. And so it's highly variable amongst radiation oncologists. And once again, I encourage you all to really ask this question of your radiation oncologist as to whether they feel the pelvic lymph nodes need to be treated. There are a couple of tools that I personally use, a couple of what we call nomograms that are publicly available online. A lot of patients will explore those nomograms, and I go over the results with people. And it gives us an estimate as to what is the risk of there being microscopic cells in those lymph nodes. And really, a lot of the trials that have looked at lymph node radiation use a cutoff of about 15%. For me personally, I think things over 10% is a bit high, and my patients are looking to reduce that risk, and it warrants treating the lymph nodes. And there's certain situations that I've written down there on that slide, like an unfavorable intermediate risk or a high risk cancer, where we usually recommend treating them. What it does is it increases the amount of radiation we give into certain parts of the body. And I'll show you an example in the next slide. And so some studies that have looked at treating the lymph nodes have demonstrated a slight increase in some of the short-term urine or bowel side effects. And so this is at the heart of the discussion. I mean, we need to really be appropriately treating people to their pelvic lymph nodes for those at highest risk. And if the risk is lower, I've seen a couple patients over the past couple of weeks where their risk was 2 to 3%, and it's not really reasonable to think that radiation is going to reduce that lower. And so I didn't recommend treating the pelvic lymph nodes. So it's a bit of a discussion that I encourage you all to have with your treating oncologist. And this is an example of when we do treat those pelvic lymph nodes. The pelvic lymph nodes are very small little glands that you really can't see, but they travel along the blood vessels on either side of our pelvis. And this is the bladder here. This is a little bit of the small intestine and rectum. And when we treat the pelvic lymph nodes, we deliver dose a little bit more to the bladder, a little bit more on either side of the bladder into certain parts of the intestine. A little bit more bone marrow is involved in that field. And so our patients tolerate it very well, but I think we need to really be discussing things at depth with whether we need to always include them or not in our course of radiation. A few more concepts as we get towards the end of the presentation here. And this is called image-guided radiation. Also something that I encourage you to ask of your radiation oncologist as to what approach they're going to use. What this refers to is, before we turn on the beams of radiation, before we deliver that dose of radiation, how are we assured that prostate, the lymph nodes, if we're treating them, are in the proper location. This is a quality check that's very common in radiation oncology because we want to make sure that our beams are going to where they need to go and that we're precisely delivering care to our patients. And that's what's called image-guided radiation. It's not unique to prostate cancer. We use it in many different types of cancer, but there's two main ways we accomplish that. The first is called a cone beam CT, a CBCT for short, and the other is with plain X-rays. These are things that are on our machine, so you don't have to be moved or brought to other areas. We do them after our therapists position our patients. We employ either one of these techniques, usually not both. The cone beam CT is nice because it is a CAT scan, so we can see a three-dimensional view of the prostate, the bladder, the rectum. It takes a little bit more time on our treatment table to do that, and so X-ray is kind of a quicker approach that for some cancers can, on its own, adequately ensure proper positioning. For X-rays in prostate cancer, because we want to see this prostate that's really not too visualized well on an X-ray, typically a urologist would place what we call gold clips or seeds into the prostate gland. So just like a biopsy would, they would, similar to how a biopsy is performed, they would actually place these seeds into the gland. And because those gold seeds really stand out on an X-ray, we can use an X-ray at that point to make sure that we're lining up those seeds that are in the prostate gland. And these are not radioactive seeds like I discussed before. These are inert gold seeds that just help us localize the radiation treatments. This is an example of those seeds. This is an X-ray from a patient that I just finished up last week, where these crosshairs are the center of our radiation beam. And what I've circled here are those seeds. So this is gold. Anything high density like gold is going to show up very brightly on an X-ray. And we know that they're in the gland because our urologist placed them. And if we line those up accurately, that gland should be right on target. And that's what we see. So we look from the front with an X-ray, and we look from the side with an X-ray. And once again, it accurately localizes our treatment, and it's a little bit of a quicker process than when we use the cone beam CT. This is an example of a cone beam CT. It's not as clear as some of our other imaging, but we can see the bones of the pelvis. We can see the prostate gland, which is in this location. This is the rectum. This is the bladder. And so obviously it's a much clearer internal image of what's going on. This green line here is where I delineated where I want my target to be. And so every day when we do this image, we want to make sure that prostate is right in the middle of that target. And we can do the same for the pelvic lymph nodes, making sure they're right in the target, and thereby keeping an eye on the rectum, keeping an eye on the bladder to make sure that there's not too much of that dose going into those organs. The benefit of this is that it doesn't require the urologist to put those seeds into the gland. And so for people who are not really interested in getting an additional, minimal procedure, we can easily localize this way. So it actually is something that a lot of my patients do bring up, but if you haven't thought about it, I encourage you once again to think about it and bring it up with your radiation oncologist to get a better idea of how they're localizing your treatments. Lastly, it's one of the newer things that we're doing and combining with external radiation. And this is something that a lot of patients are reading about and they're coming with questions on, so I thought I'd cover it today. It's called a rectal hydrogel spacer. The trade name is called Space-OR. Essentially what this is it's a gel-like material with a high water concentration that is surgically implanted right behind the prostate, right in front of the rectum. And I'll show you some images of that. So it does require an in-office procedure. But for the patients of mine that have gotten this, they've done actually very well. In a lot of cases, I've seen them the next day. A little sore, but nothing too excruciating. In a lot of cases, it's less impactful on them compared to the biopsy. And the idea behind this device is you strategically place it right in between the prostate gland and the rectum. Normally, I showed you on those CAT scans, normally they're right on top of each other. There's not much of a space. There's some high dose that usually goes to that front part of the rectum. By creating that space, you really move that rectal tissue away from the high dose of radiation. And the good thing about this is, since it has high water concentration, your body's going to absorb it. And it happens over a several month period that it's there during the radiation. In the months after, your body will break it down and it's gone. And a lot of patients don't even feel it there. So it's not like it's impacting them while it's there, but it's just, for a lot of people, nice to know that it's highly water. It goes away when essentially we're done with it. The rationale is that there were some recent studies done with 5-year results showing that upwards of 10 to 15% of patients getting radiation without the spacer had long-term bowel changes. And typically those are at about a year and a half to 3 years out. Vast majority of people will recover, but about 10 to 15% will not. And they're still reporting irritation with bowel movements, changes in bowel habits, things like that. In some cases, some serious side effects of radiation. In the study that looked at the spacer, they noted a very low risk. I've typed that down at the bottom of the slide. They did report 0% with the use of the spacer for patients having bowel issues at 3 years versus about upwards of 17% without it. And at 5 years, 0% of people with the spacer had any bowel complications versus up to 14% without. So some very compelling data here, and a lot of our patients that want to be proactive with reducing toxicity go forward with it. They do very well with it. And in the cases that I've worked with our urologists here out in Boulder, they've had a lot of success with it and haven't really had a lot of long-term issues. So, it's not a must that you have to do this. I think it's definitely worth a discussion with not only your radiation oncologist, but with your urologist to see whether they do that or not. I should also mention that when we do have these rectal spacers placed, we often like to have those gold markers in the prostate. So at the same time that you're getting this spacer implant, the urologist also places those gold markers, because that changes the anatomy a little bit. We like to have an extra precise treatment and have those markers in place. And this is how it looks. So this view on the left is kind of a side view. You can see the prostate gland here with the urethra running through it. Without the spacer, like I said, there is a thin separation between the prostate gland and the rectum. But with the spacer, you can really push that rectum away. And as we treat the prostate, where normally the high dose would be right along that rectum, it still does get some dose. So I don't want to be misleading. It doesn't completely eliminate the dose to the rectum, but the doses that it gets are not high dose. It's tend to be low and moderate doses. And here's another view of it here. This is an example of a patient I treated here out in Boulder. On this shot up here, what I've highlighted as pink is the spacer device. So typically the rectal wall, which is now down here, would be up into our higher doses. You see that gold marker that's in the prostate gland that helps us localize those treatments. And this bottom right is a side view. And so you have the bladder here, you have your prostate gland, you have the bowel and rectum coming down. That spacer is delineated here and essentially just creates a nice buffer distance for really what you see here is the high dose now going into the spacer, not into the rectum, and that's the benefit and purpose of it. So that wraps up my discussion with you today. I truly appreciate you taking time to attend this live Facebook event. We are going to have it recorded, so you can easily view it at a later time. No matter where you are or what your situation is, feel free to contact me. I have my email here, my cell phone, and my direct office number. I'm always happy when patients reach out to me. I do like email because you can type up questions and I'm happy to get back to you. But wherever you are in your decision-making process, feel free to reach out to me if you have questions about this presentation. I'm happy to address them.
Great. Thank you, Patrick. That was a very comprehensive and informative talk. So for those that are watching live with us, feel free to go ahead and write any questions in the comments, and Dr. Richard can field and answer those questions. So Patrick, as a medical oncologist, sometimes I see patients that are getting opinions from a urologist and a radiation oncologist for treatment of their prostate cancer. And this has been This has been a long-standing discussion about, who should proceed with surgery, who should proceed with radiotherapy, and of course the question isn't very straightforward, and the answer is definitely not straightforward. But just in general, when that comes up in clinic, what do you typically tell men?
Yeah, so and that's an excellent question, and a big question that we spent a lot of time on. And yeah, I mean, that it was a little out of the scope to talk about surgery, but still a very valid point to make. And that's how I really start off my consultations with patients that are still deciding between surgery and radiation. The first point I make is really for certain types or risk groups of prostate cancer. One, we don't have a high level of data supporting one treatment or the other. So the first question is, well, what's more effective? And really, for like I said, for certain types of prostate cancer, they're equally effective. And so we can't use that to help guide whether radiation is more appropriate or whether surgery is more appropriate. Um, I try to assess with each one of my patients kind of how comfortable they are with surgery, because I see a lot of people where their surgical history is almost a page. They're well familiar with the process and how they recover, and they're just more surgically geared patients to treat their body than elsewise. For patients that I kind of feel out that say, I like the non-invasive approach of this, they tend to rely more on the radiation. Side effects are a little bit different. So I think one, and I didn't get into it specifically, but one thing I like to do is get into the details of how a patient is at this point, and in terms of their urinary function, their bowel function, their erectile function, and try to help them prioritize where they rank, side effects versus treatment, because surgery does have a little bit of a different side effect profile than radiation. So yes, it's a complicated discussion. It does take a lot of time walking patients through that. But really, I think at the heart of that decision is feeling each and every one of your patients out, because there's so many different views of how they want to treat their disease and different side effects, and helping them make the best decision for themselves.
Great. Yeah, thank you. It's always a complicated discussion to have, and it's kind of the age-old debate about surgery versus radiation, and it's never straightforward. So
no, and we see this in various cancers where the treatments are so distinctly different, and usually it's a surgery versus a radiation decision that it's really hard to accrue to these really good phase 3 trials that are randomized, because patients want to choose. If they're going to undergo surgery, they don't want a trial to decide that. They want to decide. So that's kind of been the limitation with prostate cancer, is we don't have a straightforward comparison. Sure, there's been lots of high volume retrospective series showing that the effectiveness is pretty much the same for certain types, but it is a complicated discussion, and one that I spend a lot of time with all my patients.
It seems like with the use of rectal spacers, for patients that would have equal outcomes with radiation, if you can really minimize those long-term complications, especially with proctitis, that really kind of levels the playing field.
It does, because, and that's a good point, Hossein, because really the side effect that was markedly different between surgery and radiation were the bowel side effects. Our urologists are very experienced. They should not, really affect the bowel movements at all by removing the prostate gland, whereas radiation would. So in some ways, it does level the playing field, because with the use of that spacer, as I showed, those long-term side effects are much lower risk. And so, yeah, it's been nice. It's been nice having that technology available over the past several years. We've been using it, quite extensively here in Boulder, and partnering with our urologist. And it's peace of mind for a lot of our patients. Some of those numbers are not extremely high, but they want to be proactive, want to reduce the likelihood of any toxicity, and that's a good minimally invasive way of doing that.
Yeah, and then also, I'm really glad you brought up the point of proton therapy. That comes up in a lot of different cancers. More so relevant in prostate cancer than, for example, lung cancer, where you have a moving object. But with the rectal spacer, it seems like the benefits, or the proclaimed benefits of proton therapy ends up being minimal if you add the spacer to kind of standard external beam.
Yeah, yeah, no, I think that's completely valid. And another question that came up for me personally as I was making this presentation is, and I don't know the answer, is whether proton therapy centers are using spacer, because there's still some, even with protons, there's still some high dose going to that rectal wall. The challenge with protons, and I didn't get into it as much, is that it's highly sensitive to changes in density, much more so than our photon-based treatments, meaning that um, if you're putting a proton beam through air versus a solid organ like bone, that beam is going to stop much sooner in the bone because it's so dense compared to the air. And so that spacer could really change that. And so, yeah, it's a very good treatment modality, but one that's a bit more complicated. And but still, like you said, it comes up all the time. So I definitely always bring it up to kind of round out discussion with patients.
Yeah. Well, great. I think we're at 12:55. We don't have any questions, but if you all do have questions, I know at the noon hour, a lot of people at work and aren't watching live. So feel free to leave any questions, and we will route those questions over to Dr. Richard to answer. But Patrick, I really appreciate you doing this. It's a wonderful discussion. We're going to have it saved online, to reference in the future, because this will be a discussion that a lot of patients want to have, and having, gosh, almost an hour of you talking about this is going to help out a lot for patients. So I appreciate it. And if you all have any questions, again, go ahead and leave those comments. And I think we're done.
Yeah, my pleasure. And feel free to look, like I said, on that last slide with my contact information, send questions along the way. But it's been a pleasure joining you today, and appreciate you having me.
All right. Thanks, Patrick.